Thank you. It's dear colleagues, dear chairman. I'm honored to be here with you, and thank you, the organizing committee, for the privilege to share with you this presentation. It's many ways to. Some considerations can be made when you want to compare two techniques addressing the same pathological situation. In this situation, this is the primary mitral insufficiency. Somebody has to bear in mind the severity of regurgitation, the valve anatomy, the patient factors, the long-term outcomes, and most importantly, the surgical expertise. And we assume and best demand from the surgeon to be expert either producing these both techniques or each of them. It depends which one it's allocated to, and to perform that flawlessly. Of course, in being a human, it's flawless, maybe it's a bit heretic. And there are other considerations as well. Is there an absolute indication for the operation? That's the first thing somebody has to ask. Is there a suitable anatomy for both techniques? Is it the similar cohort of patients, or there is a gross heterogeneity? And again, you can see that the variable, which is very important, is a solid reference point, is the surgical expertise. And of course, to have complete follow-up to compare these techniques and not have missing data. Most of you have seen, especially in some propensity or even observational studies, that after the first or the second year, there is a diminishing number of patients at risk. Not because these patients die, they are censored, but they are censored because they're missing data. And of course, there is another way as well to consider this thing. It's suppose that you can offer prognostically an operation. It's a patient that is borderline for the procedure with a good ventricle, not dilated, and you think that it's maybe I can offer a valve repair procedure in this patient, especially if it's young, provided that I can offer a procedure that it will be 98%, if it doesn't sound pompous, to be a mitral valve repair. Of course, here again, you have to bear in mind the variable anatomy. If the patient is young or old, it will depend on what sort of operation we can offer. Again, the surgical expertise, we can never forget that. That's the most important thing. And of course, somebody has to bear in mind when comparing these techniques, the survival, the long-term survival, the clinical status, the quality of life. And of course, we shouldn't consider the reoperation, the redo mitral valve, as a surrogate for a failed mitral valve repair. And of course, there are established practices in mitral valve for mitral valve reference centers regarding both hospitals and surgeons. These are the prerequisites that must be somebody must have. One of the recent studies, and Dr. Mack is here as well, it was a large study covering a large STS database from 2011 to 2016, having 55,000 patients. And you can see at the upper part of the slide is the hospital data, and the lower part is the individual surgeon's data. You can see on the left side, it's crowded. Crowded on the first slide, it's the attempted mitral valve repair, the planned repair. But the successful repair after that, in the next slide, you see next figures, it just gets diluted and has to do with the annual volume of both the hospital and the surgeons. And again, more contemporary data that emphasizes on this thing. Again, you can see that the median number of cases annually for a mitral valve repair, it's 5. It's quite low. And mind you, I had a look at our hospital about doing around 1,900 cases, and we are about 54 as well annually, which is, it's not bad, but it's, if you consider that on the individual surgical basis, most of the surgeons, they are on the very low single-digit figure. But again, from this publication, it appears that the mitral valve repair is a very safe procedure, even for the reoperations. And of course, you know, this publication, maybe it sounds, again, as I said to you, a bit pompous to say that I can repair 100% of my valves. But of course, if you are a center of excellence with big experience and you are very choosy with your patients, you can have excellent results. And coming to the most of the management of these patients, you can see it's green everywhere. It's mitral valve surgery. It's indication type 1, except for these patients with no symptoms and dysfunction that the TER can be helpful. And coming again to the to be more pragmatic, you can see again, it's a surgical valve repair, surgery repair whenever possible. You don't see anywhere valve replacement. And of course, it's following this platitudinous prologue that maybe it was boring for you. It's because there are no data. There are no large prospective randomized trials comparing mitral valve repair to mitral valve replacement. Of course, regarding, I mean, the primary mitral valve insufficiency. There are for the ischemic, yes, and the transcatheter procedures, yes. And of course, some of you, being in PIs for RCTs, you know what an ordeal it is to deal with RCTs. It's a matter of feasibility. It's always trying to find the economical issues, also collaboration within hospitals, the funding issues, ethical sometimes, especially if you have two techniques that one of them is better than the other, and the patients know that. And normally they select, they want to do a certain procedure. And there is also the clinical equipoise, especially if there is an uncertainty between the investigators. The endpoints and the sample size is very important, and especially the endpoints. It's no point selecting endpoints that they are meaningless. It's to find a statistical significance, but with meaningless results means nothing. They say that it's you must have evidence that matters to the patient, not to the investigator or to the industry. Of course, patient selection and standardization is very important. The patients, in both techniques, they must have the same follow-up, they must have the same protocols, preoperatively, postoperatively, the same care. And the standardization, of course, again, when sometimes when the human factor comes in, it's a bit difficult. When you want to compare surgical techniques, certainly surgeons, most of them, they are seasoned and experienced. They do the operation theoretically flawlessly, but again, there is that human factor. And long-term follow-up with complete follow-up will be necessary. And of course, the most difficult thing with the RCTs is to take the results from a calm sea and adapt it to the ocean of the real world. These are more or less some of the meta-analysis and the observational studies comparing, and there are far more, and all of them favor regarding operative mortality, adverse event, and long-term survival, the mitral valve repair. One of the recent studies here, which again was propensity matched, again found that the morbidities and the long-term mortality were better with the mitral valve repair. Here you can see a hazard ratio. It shows that the mitral valve replacement is always above 1 across all ages. But the question is it a durable repair? I mean, it's very good to do your repairs, but it has to be durable. Especially for the elderly patients, sometimes it's better to have a chordal sparing valve replacement instead of doing a repair that you're not happy with it. And again, another pooled study shows the same thing. Not much difference when compared to redo cases. But again, here, it's when you do mitral valve repair procedures, you have the MVR. It's your lifeboat. It's a bailout procedure. It's not the other way around. And there are some confounding factors too. For instance, you end up selecting easy cases for the arm that does the repair. And so that makes things a bit more complex. Even from recent publications, it's supposed that the mitral valve repair fares better with reverse remodeling of the heart. But again, from this group, the patients that they went to the MV repair, they had mostly disease of the posterior leaflet. Of course, this is probably the only case when you have this mixed disease. It's most of the time a rheumatic disease. We hardly ever see it nowadays. But surgeons from Asia and Far East, that they have very good experience. They are seasoned surgeons, really, that they have produced very good results repairing these valves. Most of the cases, when we have cases like that and we have to do them surgically, we'll replace the valve. So what happens in the real world? This is the real data. We have the type 1 mitral insufficiency. We don't see it that frequently. This can be repaired. If there's endocarditis, some of the damaged tissue can be repaired, can be patched or whatever. If it's type 2, that most of the patients that we have, this can be repaired with various techniques, from resecting, respecting, doing Alfieri, doing plication, folding, etc., putting artificial cordy and the rest. And the type 3, it's again a rare procedure that, as you saw before, it's mostly due to rheumatic disease. So these are gone. There's not much left. And I think that probably this is going to be a nice assist, if I want to use a basketball term, to the next distinguished speaker. Maybe the question should be, do we need surgical mitral valve intervention or transcatheter interventions? These are things that are coming. They are scheduled to large studies that it will take a long time. They will not end in the near future. And you can see when they start, when they're going to end. And maybe some years after that, I don't know, probably won't be here. It's the topic and the title of my presentation should be surgical or transcatheter. And I don't know that, but I conjure Diva Fortuna to give us good health so that in the near future, in the distant future, we'll be able to have these things. Thank you very much.
Great, thank you very much. We have time, although we are running a little bit late, we have time for one brief comment or question to Dr. Stavridis.
Or, this is going to dovetail into the next talk very well, so we can also have the next talk and then discuss both surgery and transcatheter, as one time, because I think from the surgeon standpoint, we really fixed degenerative MR really, really well. It's going to be interesting to see how these trials turn out.
Yes. That will take time, though.
It will take time. I'll be retired by then.
Okay, great. Thank you very much. We have to move now to the